Hello, Assalamualaikum. Okay, so yeah, 5 people. Four. Okay, so let's start because we actually get very late on finishing one paper. Okay, so let's begin our this paper, and it's almost 50% is almost repeat questions you must have done previously in those 6-7 recalls. Okay, so this was about the magnesium excretion. This is again, it actually appeared in so many previous questions, so that is why we written that. So magnesium does not any process, it is excreted unchanged through the kidney. Okay, so not metabolized or not conjugated, it is just absorbed and just it is excreted in the same manner. Lifetime risk of breast cancer in general population, a very important risk of this breast cancer and also the ovarian cancer. So these percentages are very important, you need to remember. See, this we have discussed in our class as well, that the lifetime risk of developing ovarian cancer in general population. So you need to see the STEM very carefully, that they are asking you about in the general population, or they are asking you in those patients with having some mutations of BRCA1 or BRCA2. Okay, so in general population is the overall lifetime risk, and that is 1 in 70, or if you take it in percentages, it is 1.3%. Same with the breast cancer, the risk within the general population is 12%. Okay, so 1.3% for ovarian and 12% for breast cancer. And again, with this BRCA1 and 2, inherited ovarian cancer are 6 to 8%, and inherited breast cancer, this is overall risk of breast cancer. Okay, so BRCA1 and BRCA2 involved in the whole causes of the breast CA just less than 2%. Okay, but if there is BRCA1 or BRCA2 mutation, then the risk of having breast CA and the ovarian CA is different. Okay, so don't confuse yourself in these three risks. There are three kinds of percentages we are discussing. First is the lifetime risk of having any CA, whether ovarian or breast CA. Basically, these two are important in the general population. So general population, you don't know any mutation or any kind of change in the patient. So this is about a general population risk, that is 12%. But if you take whole of the breast cancer cases, we say that the inherited causes are in just less than 2%. Okay, and out of those inherited causes like BRCA1 and BRCA2, whenever any patient has BRCA1 mutation, then the chances of having breast CA and ovarian CA, these two percentages are now different. So these percentages are very, very important. So BRCA1 has risk of breast CA 60 to 90% and ovarian CA 40 to 60%. If you just take a rough estimate or middle one, 70 to 75%, and this is the 50%. So do remember at least 1% in the middle. So BRCA2, again, it is about like 50, 60, 70, 80. This is actually a big range from 45 to 85. So you can remember like this here again 70, but here the difference between these two, that ovarian cancer risk is a little less, just 10 to 30%, or you can remember 20, around 20. Okay, so just remember one number and then you can say, okay, some a little lower and 10 a little upper. Okay, so this is how you can remember just a rough estimation of the percentages of these BRCA1 and BRCA2. Okay, okay, so that is about a picture you may get in exam. Almost in second paper you may get the pictures of, like, this is a microscopic picture of this this is a protozoan, which is a parasite, and which has 4 flagella, and that is Trichomonas vaginalis, you all know. Again, you may have, like we have discussed, I think previously, or in this paper, the histology of some diplococci, you know that, which is Neisseria gonorrhea, and you may have ultrasound pictures. So ultrasound pictures are again very important. Even the fibroid we have discussed in one class. So any kind of fibroid may come intramural, or it is subserosal, or it is submucosal, would be inside. Okay, then you may have ovarian pathologies in ovaries, Usually they ask you about endometrioma, which is like this ground glass appearance, that is the homogeneous texture. And what else? The snowstorm appearance of molar pregnancy. That is again a very important point. So snowstorm appearance would be like this in the on the ultrasound. Then the twin pregnancies. So these 3 4 pictures, ultrasound pictures, are very very important. You may get in exam, and they usually take the pictures from Wikipedia. So if you write just the molar pregnancy on ultrasound, complete molar on ultrasound, whichever the most typical picture comes on Google, that can come in exam. Okay, so we have taken almost all the pictures, like we'll be discussing in the recalls almost all these pictures. Okay, so again, a very important topic about the Coombs test. So Coombs test, usually they ask you about, like, they may give you a picture like this. If you get a picture, and then they may ask you that, okay, diagnose which is this test, or they may ask you about that which test you will be applying on the fetal blood. That is again a direct Coombs test. A very easy way to remember this figure, that whenever you have a one step process and you see that this blood, the blood taken from this patient, this is the patient, and you take the blood. So this blood actually has, see, red are your RBCs and these Y are your antibodies. So these RBCs are coated with the antibodies. It means they will be the fetal blood. Okay, and you are just going to add the reagent, and they would be combining and doing the agglutination. And always one step procedure is your direct Coombs test, and indirect would be two-step procedure. See, there are 2 steps. So in indirect Coombs test, you know that you take a patient sample, and here patient sample would be just having the antibodies. Why? Because you take the blood and you just take the serum of the patient. You are not taking the whole blood, because you know that RBCs and blood are like your whole blood is equal to serum plus RBCs, or all the cellular products. Okay, so you are taking serum. Serum means blood minus your all the cells. So RBCs are not present in the serum. So here you are just taking serum because you are just going to see the antibodies, and you take Rh positive RBCs, and then take the antibodies. Now, when you mix these, the antibodies will attach with the Rh positive RBCs. And when you give this reagent, this is actually the reagent here as well, here as well. This is Coombs reagent. When you add this one, and all the cells would be agglutination would occur. They will be clumping would be there. So this is the step of indirect Coombs test. And again, if you see this kind of picture, this was again one step is your direct Coombs test. See, in direct Coombs test, you are having RBC coated with the antibodies. This is the difference to diagnose. Diameters. Again, skull diameters are very important. This is how you may get a picture, and these would not be labeled. So you need to label, or they may ask you about the diameter. So you all know that the vertex presentation, this one is your vertex and this is your sinciput. The vertex presentation would be having the diameter of, see, this is your occiput or subocciput, you can say, because this is the occiput, subocciput, and this is your bregma. So bregma is the main your position. So subocciput or bregmatic is your presenting diameter of 9.5 centimeter, and that is the least diameter in the skull fetal presentations. Okay, so that is the most comfortable, most favorable for the vaginal delivery. Okay, likewise you can say that whenever and it is in the fully flexed head. Okay, so that is the flexed head. When you have, then the diameter presentation would be the suboccipitoblegmatic. So they may ask you like the most favorable presentation, or they may ask you the presentation in the fully flexed vertex, what would be the presenting diameter. They may ask you in the different manner as well. So again, the diameter would be suboccipitoblegmatic, and it is 9.5 centimeter. When the head is a little bit deflexed, okay, so deflexed go beyond, like deflexed, a little extension you can say. So deflexed head would be, vertex would be, now the diameter would be starting from occiput. Hey, this was a subocciput, now it goes this side, Suboccipital to frontal bone. This is the frontal bone. So this is your occipitofrontal. Now the diameter is 11.5. Okay, so this is a deflexed vertex. Now, if you go for a fully, like you can say that extended head, then what you see, this is the diameter starting from mentum till the vertical. This is the fully deflexed head, or you can say that extended head. Okay, this is in this presentation, the bro presentation would be the presenting part. This one is your presenting part, that is the bro presentation, and that is the longest diameter in the fetal delivery, which is mento-vertical. Mentum is the chin bone, and vertical, mento-vertical is 14, or we actually take it as 13 centimeters. So you do remember 13 centimeter, and that is not favorable for vaginal delivery. That only cesarean section would be in this presentation. So bro presentation, or the longest time presenting diameter, or the diameter which is very unfavorable for the vaginal delivery, is the bro mento-vertical, 13 centimeter. Okay, and again, if they ask you about a face presentation, like this is a fully extended, but the face would be presenting part would be this one, the whole face is presenting part. Okay, now this presenting part, the face presentation, again the diameter would be starting from this chin, which is mentum, and it goes to this bregma, this one bregma, which is submentobregmatic. Again, this face presentation has also the least diameter, which is likewise the reverse of the flexed vertex. And that is again the 9.5 centimeter. So they may ask you question like this, that the diameter in the face presentation would be how much, that is 9.5 centimeter, or the diameter in the bro presentation, that is 13 centimeter, the diameter in the fully flexed vertex, that is the suboccipitobregmatic 9.5 centimeter. So they may ask you in different manner, and all these diameters are important. Suboccipitofrontal you may remember, but it is just like the suboccipitobregmatic. So there is no much difference between this suboccipitobregmatic and suboccipitofrontal. Okay, so half-lives. Again, all these 3-4 half-lives are important. Mifepristone, just you know that we give in for the miscarriage, and we give at least 24 to 48 hours before starting the misoprostol. So the duration would be 25 to 30 hours half-life. Okay, half-life of LH is your luteinizing hormone is 20 minutes. It's a very repeatedly coming question. Beta HCG, you all know it is 24 hours. Half-life of FSH is 3 to 4 hours. Okay, so all these half-lives are important. Reltigrase mechanism of action is the integrase inhibitor. And these vaccinations, these are very, very important. This table is very important. You need to remember. Hepatitis B vaccine, they may ask you. HPV, human papilloma virus vaccine, they may ask you this vaccine. Vaginal delivery possible in phase presentation? Yes, it is possible, but mento anterior can deliver, mento posterior cannot deliver. But they don't ask you this question, that which phase presentation can deliver. Okay, but they can deliver. Mento anterior do deliver. Okay. Okay, so these vaccinations, this hepatitis B, these new vaccines, you can say the subunit vaccine, or even these biosynthetic or conjugate vaccines, these are the new ones. So you may be asked these vaccines. So see the subunit vaccines, your hepatitis B vaccine, your typhoid, your hepatitis C, you may just skip because it is under trial. And this conjugate in Haemophilus influenza type. And HPV is also this subunit vaccine. Subunit has this name, the recombinant as well, the polysaccharide as well. And conjugate, they might be different from the subunit, but they usually are a same combination. Okay. So you may consider conjugate. If you have a separate option of conjugate, then you may select conjugate for only Haemophilus influenza. Otherwise, all these options you can select for HPV. And you know, the live attenuated vaccines you cannot give in pregnancy. So these are also important. You need to remember. The killed vaccines, again, and toxoids are just these two, diphtheria and tetanus, that are easy ones. Okay, so this was a microscopic picture of Neisseria gonorrhea. So you see diplococci, and you have to mark the cancer associated with mutation of mismatch repair gene. Mismatch repair genes we have discussed in class, that they are linked to the Lynch syndrome, HNPCC syndrome, and the cancer associated. So basically, there are many cancers: colorectal, endometrial, gastric, ovarian cancers. All are have the risk of having the cancers in this mismatch repair genes. But usually, the endometrial CA has the most burden, around 40 to 50%, and even ovarian CA 4%. So we don't know the other options, but still endometrial CA is the topmost in the mismatch repair gene. So this is again from your book, ovarian CA with endometriosis. So with endometriosis, you know, it is a clear cell carcinoma, phase preceded by mitosis. This is the cell cycle. And this is again a very important, that how the cell divide and replicate. So I'll just give you a quick revision that the cell starts from this point. It enters the gap one. The gap one is just a resting phase. You can say that the cell just prepares itself for the synthesis phase. So cell enters this S phase, the S phase where the synthesis occurs. S for synthesis. Synthesis means replication occurs, because you know that for every cell to divide into two cells, the DNA has to replicate. This is the DNA. It has to be replicated into two first, then the cell will divide. Okay. So in this S phase, the two DNA are formed, and then in gap two, again the cell prepares for the next step, which is the mitosis. So these are the whole steps starting from G1, then is the S phase, then is the G2, and then is the M phase. So these four phases of the cell cycle, and they may ask you that what are the phases of cell cycle, what includes the interphase. These three phases are included in the interphase, G1, S, and G2, and then is the M phase, which is mitosis phase. Okay, so these, okay, so now the G naught as well. G naught is like a resting or quiescent phase, which the cell does not divide. Like if you say the example of neural cells, you know, they don't replicate. So it means those cells just enter into that quiescent phase. So G naught, G0 is the resting phase, that they do not replicate. Okay, but there may be sometimes like those cells which just enter into the resting phase, and when the time comes, or when the stimuli of replication it comes, then they may enter into the replication. So this is a resting phase, but maybe it depends on the cell. Maybe it enters into this division cell cycle, or they may retain into that quiescent phase. So this is dependent on the cell. It does not depend on the cell cycle. Okay, so you just need to know a bit understanding, and then you need to know which phase comes first, or which phase precedes this phase, or which phase comes after this phase. So this is how, just remember the sequence: G1, S, G2, or M, like the phase preceded by mitosis. So before mitosis is your G2 phase. This is very easy questions. Okay, RNA analysis, southern blotting, the PCR. These three are again very important. You all know the RNA is for northern blotting, southern blotting is for DNA identification. And whenever they ask you about the amplification, that would be your PCR. Okay. And the enzyme used in PCR is your Taq polymerase. So all these three questions related to only one topic. Okay, heparin structure, glycoprotein option, polysaccharide protein. Heparin is a polysaccharide. So this we have discussed all these four: southern DNA, northern RNA, western blotting. Okay, we skip, which is for protein. And PCR is whenever you have a question where you say that they say that amplify a sequence of DNA or RNA, then you don't go to southern blotting or northern blotting. Whenever you see the word of amplification, then just PCR would be the option. Okay, so rate limiting step in the synthesis of catecholamines. So we have discussed the catecholamines, that the first step of tyrosine converting to this DOPA is catalyzed by this tyrosine hydroxylase. So do remember now that the amino acid tyrosine is giving how many enzymes? First, yesterday we have discussed the tyrosine do convert into the thyroxine hormone, and also these whole catecholamines and even the melanin. Okay, so these three are very important. And I think we have discussed the serotonin. What was the precursor of serotonin? Who will tell me? Which amino acid gives rise to the serotonin? Because 2, 3, I think 3 amino acids are important. Tryptophan, yes, very good. So tryptophan is the amino acid for the serotonin. So tyrosine, tryptophan, do remember very clearly. So this is the first step, which is the rate limiting step, and the enzyme is the tyrosine hydroxylase. So rest you can like skip these these enzymes. You know, this is very difficult. Aromatic 1 amino acid decarboxylase or all these things. So just first step, you may remember the tyrosine hydroxylase. That is important. Okay, so uterus and cervix ratio in postmenopausal women, it is actually 1 to 1.5, they usually say. So you can say that 1 to 2 around. Okay. Ratio of T4 to T3 in blood. So these T3, T4 are very important. These we have already discussed, 14 to 1. So 14, like more is concentration is the T4 and the less concentration in the of the T3. Larger cell in the body. See, cardiac muscles, spermatozoa, red blood cells, these are not largest. You may see the diameters, which micron diameters, but the oocyte is in the millimeters. So this is the largest cell. Mode of inheritance of BRCA1 and 2. BRCA1 and 2 are very, very important. So autosomal dominant mode of inheritance, the percentages, the mismatched repair genes, all these are important. This question we have discussed, I think, in first or second recall, that how much weight should be reduced to reach the BMI of 30. You all of you know how to calculate, or should I repeat? We have discussed in a previous recall, if you remember, or we can just do it again. Let's do it again. BMI, the formula is the weight divided by, repeat karne ke, thank you. Okay. The formula, just remember the formula. Whenever you find a stats question, do write the formula. Okay. So you know that BMI is equal to weight divided by height square. Okay. So they have just tell you that first was the BMI is 40 and now she wants to go to BMI 30. So let's put the, let's find the weight currently. So, you know, the BMI is the 40 now is equal to weight. We have to find the weight, current weight, divided by height is meter square. Now they have written 2 meters. If it is to 100 centimeters, then you have to convert into meters. So 2 into square. So 40 into this would be multiplied by 40. 40 into 2 square is 4 is equal to weight. So 40 into 4 is your 160 weight. It means this is the current weight of this patient. Now, how much weight should be reduced to reach the BMI of 30? Now, just put the BMI 30 and then the weight would be, you will be fine. See, you just put the weight 30 in spite of 40. 30 into 4 is equal to your weight is equal to 120 weight. It means she has to go from weight 160 to 120 for her BMI to be reduced from 40 to 30. So it means how much difference she should be gained, like how much weight she should be reduced to reach the BMI of 30. That is 40 kilograms. Okay, 160 minus 120 is equal to your 40 kilograms. This much should be reduced. Epidural anesthesia between, you know, it is epidural. So above dura and above dura, what would be there? Only vertebra would be there. There would be no other layer. Horner syndrome. So Horner syndrome is like, it's the past question we have. We know that it is a sympathetic supply is disturbed. If you just see that, the typical picture of Horner syndrome, that sympathetic actually slide disrupted on one side. So face and eye features would be there, and very typical eye features are there. The ptosis, which is drooping of eyelid, meiosis, you know, constricted pupil inflation, and hydrosis, no sweating. These are the 3 typical features of Horner syndrome, may caused by any trauma, block, any tumor, infection, or any spinal cord injury. Okay, so just they are asking you about that, which supply demolished in this Horner syndrome. This is sympathetic. How does oxytocin act to achieve uterine contractions? So Uterine contractions, you must be knowing that, okay, serum calcium should be increased because all the muscular activity needs the serum calcium. Now, this a little bit of biochemistry, if you just see this picture, see the uterine contractions are your oxytocin and prostaglandins, and relaxants are your nitric oxide, relaxant, and progesterone. So, you know, progesterone is uterine relaxant. It would not entering into the contractions. So contractants are working by calcium and relaxants by cyclic AMP or GMP. Okay, so just this thing. Then they said just that both of these hormones mean oxytocin and the prostaglandins, they activate phospholipase C. Okay, and then they just increase the intracellular calcium. So this is just the mechanism or just the biochemistry of uterine contractions. This is how it occurs. And you need to remember that this oxytocin actually originates from the uterus rather than the posterior lobe of pituitary gland, which occurs in the during the labor. Okay. Okay, so coming to the lasers. Laser types we have discussed in biophysics, which is type is the Nd:YAG. There are three types of lasers: gas laser, solid state, and liquid. Only two lasers are important you need to remember. The one is carbon dioxide laser because we usually use in the cervical pathology, and the second one is the Nd:YAG lasers. These two are very important. So this is the solid laser, this carbon dioxide is the gas laser. Which amino acid liberates nitric oxide? So again, another, this was the third amino acid I was talking about. That these three amino acids you need to remember. This is actually L-arginine. This nitric oxide is produced from L-arginine by the enzyme nitric oxide synthase. So this amino acid is very important. So tyrosine, tryptophan, and L-arginine. Which enzyme renal tubular cells are responsible for production of ammonia, and that is your glutaminase enzyme. Histones, we have discussed that they are the histone proteins are packed in the DNA. So all the coiled DNA, the histone proteins present. Okay, so this you need to remember. These are proteins. Dinoprostone. Dinoprostone is your PGE2. Misoprostol is your PGE1. Carboprost is your PGF2 alpha. GnRH structure is your DACA peptide. This is again a very important. We have discussed in biochemistry, and I told you that these structures you need to remember which one is polypeptide, which one is those were about the amino acid derivatives. One were the peptides, and the third one was steroid precursors. Okay, so steroid hormones. So there are three types of hormones, so you need to remember that as well. Okay, foregut blood supply. So there are three blood supplies of gut. One is the foregut supplied by the celiac trunk, midgut supplies by the superior mesenteric artery, hindgut supplied by the inferior mesenteric artery. Okay, appendicular artery, again, it's a repeated question. It's a branch of, first is the superior mesenteric artery. It gives a branch of iliocolic artery, which give some posterior cecal artery. And this posterior cecal artery give branch of appendicular artery. So you need to remember all this pathway. You may get, like with the iliocolic artery, there may be another option of posterior cecal artery. Then you need to select that posterior cecal artery because this is more specific for the appendicular artery. Okay. Okay. So hysterectomy, they just ask you that which nerve passes in front of source that should be preserved. So again, your lumbar plexus nerves are very important, which passes medial to the source, which passes lateral to the source, and which passes in front of the source. So there are three nerves. Genitofemoral passes anterior, obturator medial, and rest of all the nerves passes through the lateral side of the source major. Okay, so this we have discussed previously again so many times. So these 3 points you need to remember. Okay, Brenner tumor consists of which type of cell? See, Brenner tumor. Brenner, whenever you get this Brenner, you need to see the spellings very carefully. Brenner is always your ovarian tumor. The Brunner glands, we have another question previously, I think. These Brunner glands are present in the duodenum. Don't go direct if you just see the Brenner and just stick the duodenum. These Brenner cells, the actually in the Brenner tumor would be present in the ovary. And this Brenner tumor would be having the transitional epithelium. That is important thing. Again, there was a question previously that the malignant status of this Brenner tumor, that is, we have picked up the least option, less than 5% previously. So maybe less than 2%. If there's the option, then you may select less than 2%. So you have to select the least one. Okay. And this Samoma bodies, they have calcium, they are associated with serous cyst adenoma. So these are the questions that are very, very important. See, transitional epithelium is there. Female urethra, the cancer. So always the cancer would be the same like the epithelium. So female urethra, the epithelium would be the squamous epithelium near the vagina. So then the type of cancer would be the squamous cell carcinoma. Okay. Again, the woman with 6 centimeter cyst, heavy menstrual bleeding, multicystic cyst, solid area, CA1 to 5 is 45 RMI score. So it means it is a premenopausal woman. She is having bleeding. So premenopausal score is 1, CA1 to 5 is 45, ultrasound score. How many features are these in this question? One is multicystic, the other one is solid areas. So whenever you have two or more than two ultrasound features, then the score would be 3. So you need to multiply it by 3. So this would be your RMI score. Bacterial vaginosis, causative organisms. So they may ask you the other causative organisms as well. See, Cardinella vaginalis, we have already we discussed, but the other microorganisms, including bacteroids, mobiluncus, or mycoplasma. So they may cause bacterial vaginosis as well. Okay. Okay, so this was a question about the layers penetrated by sperm. Again, this was a previous question we have discussed, but here see the picture, then you will be very clear the outer one. So you need to remember the sequence, that is important. You may get all these 4 names in the question, but you have to remember the sequence. So the first outer one is these cells, they are corona radiata. So the cells first, the sperm has to pass first through the corona radiata. Then the zona pellucida is actually a glycoprotein-like layer. Okay, and corona radiata are just cells. So first outer is the cell, then is a layer, which is a thick layer, or you can say a very thick glycoprotein layer, protective layer for the egg, which is zona pellucida. That is second number. And then is the perivitelline space, and then the vitelline membrane. So these are the 4 layers which have to pass by the sperm. Okay, so now the sperm, there can be questions like 2-3 questions in this sperm activation. So you need to read this either from the notes or from the book. So sperm penetration. So first is the sperm activation, then sperm penetrates corona radiata, and then the sperm attach and penetrate zona pellucida. And after that, the membranes of the oocyte and sperm cell fuse. Okay. So first, when the sperm has to activate, then it has to undergo a process of capacitation. So you need to read these words, that what is actually the capacitation. So in this capacitation phase, actually your glycoprotein and cholesterol of acrosomal membrane, they are removed. Okay, so this is a change in the sperm. Then what happens when the sperm comes in contact with corona radiata? Now what happens? Now another reaction, which is acrosomal reaction, occurs. What it do? In this reaction, they release hyaluronidase. What is the function of this enzyme? This enzyme is required by the sperm to penetrate the corona radiata. Okay, so it means the first one is the change in the sperm itself, that the sperm's glycoprotein and cholesterol are removed, which we call as capacitation. Then for the penetration, the sperm needs to release an enzyme which is hyaluronidase, and that reaction we call is as acrosomal reaction. So this is the question they're asking, that sperm penetration releases enzyme. What kind of enzyme is it? It is hyaluronidase. Okay. Then after that, the path of corona radiata is cleared, then the sperm binds to the zona pellucida. So these are the layers, corona radiata, then the zona pellucida. And now for the zona pellucida, again it releases its acrosomal enzymes. Now the enzymes are the different: esterase, neuraminidase, and acrosin. Okay, so these three enzymes now they are released that they bind to the zona pellucida. And now what happens, that zona reaction occurs. So first was capacitation, then the acrosomal reaction. Now the third is the zona reaction, which changes the uh, capability of the sperm, so that of the egg, so that no more sperm attach. So prevent attachment of more sperms. So only this sperm actually has the ability to go inside and fuse with the oocyte. So the next step is the oocyte and sperm cell membrane fusion. So when it passes through the zona pellucida, then it goes to the perivitelline space, and then it contacts with the cell membrane of the oocyte, and then the fusion occurs. So these are all the steps of the sperm activation and penetration. Okay, so okay, this one was the question. Okay. Drug of choice in chlamydia. So again, we have discussed the chlamydia, gonorrhea, all these things. So drug of choice in chlamydia, always your, in the pregnant, if they ask you, then you can say azithromycin. Otherwise, on the non-pregnant patient, doxycycline is the most suitable one. Okay, so you need to see the stem. If it's a pregnant, then only azithro. Otherwise, you can take azithro in both, or if the doxy is not there. Otherwise, usually we start giving the doxycycline. And for the gonorrhea, ceftriaxone 1 gram IM single dose. That is the drug of choice. See the ceftriaxone for gonorrhea. Okay, so this is a question about the syphilis, and I think I have added the chart later on. So I'll discuss this question later on. Okay, 49 question. Okay. This is the question about HIV. Viral copies are 16,000. What gestation latest should we start antiviral treatment for HIV to prevent vertical transmission? So basically, the guideline, we have a so big guideline on HIV, and they say that all pregnant women should start ART during pregnancy. Okay, this is the recommendation. Now the recommendation is that if you just see the viral load, they say that if it is less than 30,000, then it should be started in the second trimester. If it is more than 100,000, more than 1 lakh, then should be started in the first trimester. Otherwise, if you don't remember these 2 points, just remember that all women should have commenced ART by week 24 of pregnancy. Basically, the question here is not clear, but maybe you may get the question if it is about the viral load, that is 16,000. See, the viral load is, if it is less than 30,000, then in the second trimester, they have not mentioned any week. See the options 20 week, 24 weeks, all are second trimester. So just they are asking that when it should be start for every woman to prevent the vertical transmission, and that is the week 24 of pregnancy. Up till this, after this week, this should be started for all pregnant women. Urethral orifice, which space deep perineal pouch, we have discussed already. Genital mutilation, although it is not a topic of your, it have a big guideline on, it is part of MRCP2. But if you just see that FGM, we have 4 types: type 1, 2. What happens? Okay, so this. Okay, so type 1, 2, 3, and 4. So basically, if you just see that this one, blue one is your injuries, that what actually they are cutting. So in this type 1, they're just cutting the clitoris. So clitoridectomy is in this type 1. And then with this clitoris cutting, the labia minora or majora may cut. So this is type 2. I think you need to remember these 2 types, but you may see, just have a reading. Okay. See, type 1, partial or total removal of clitoris. Clitoridectomy is type 1. In type 2, clitoris as well as labia minora with or without majora. So minora is compulsory. Clitoris plus labia minora is compulsory. Majora may or may not be there. So excision we say the whole word. Type 3 is the narrowing of vaginal orifice. If you just see that everything is stitched in this picture. So in type 3, actually, everything is stitched. So they are just covering, creation of a covering seal. Everything is covered. For this, we take a word of infibulation. Just remember this word. And type 4, other things like pricking, piercing, incising, scraping, cauterization, burning, any other thing would be, any other procedure done to the genitalia would be in the type 4. So usually they may ask you, give you the picture of type 1. So see, this would be cut, this would be clitoris, then it would be type 1. And if minora is also, then it would be type 2. So just remember these two. See, MM1 vaccine we have already discussed. It is a live vaccine. Fatty acids passes through placenta, passive diffusion, collecting duct, embryological origin. So this was all about the kidneys, and you need to be very careful by attempting this question. So I think we have sent in the group that the renal tubules, see, if you remember the lecture, that the one is the ureteric duct, which is this ureteric bud, then it induces the mesoderm, surrounding mesoderm induce, and that form the mesonephric, metanephric blastema. Okay, so this one portion, this is the mesoderm. So this metanephric mesoderm forms these things, and all your collecting duct system, all your ductal system is formed by the ureteric bud, and that ureteric bud is the mesonephric duct. Okay, so collecting duct, all your calyx, renal pelvis, ureter, everything formed by the ureteric bud, which is mesonephric duct. But if they ask you about the renal tubules, glomerulus, capsule, all these tubules, then that is the mesoderm. Okay, so do remember this thing. Okay, appendix of testis is the paramesonephric duct. Remnant, oxybutynin side effect is the dry mouth we have discussed. Okay, HPL, human placental lactogen. I think where question gone? Okay, this is the question which is not under the control. So question is not complete, but they are just asking that it is not under control of hypothalamus. So from where HPL is coming? So it actually, the trophoblast, syncytial trophoblast, they actually synthesize this HPL. Okay, so you need to remember that this is formed from the placenta, and it is similar to prolactin and pituitary growth hormone, and its concentration plateaus after 35 weeks, means the peak is after 35. So all these 3 points are very important for human placental lactogen. And this HPL is actually the tumor marker in placental site trophoblastic tumor. So choriocarcinoma, whenever they ask you, then the tumor marker is your HCG. And if they ask you about placental site trophoblastic tumor, then this HPL is the tumor marker. Okay. The Rice-Tyler phenomena is in the endometrium. Sacroiliac joint is synovial joint. Fetus gets cholesterol from where? So it's a fetal liver from where the cholesterol comes in, and then all the labor process starts. HPL similar to growth hormone and prolactin. Okay, if the patient is on lamotrigine and sodium valproate, so congenital malformations. So basically, if you just see this picture, it is from a TOG article of epilepsy. They just say that congenital malformation risk, a background congenital malformation risk is around 2 to 3%. See, 2 to 2.3% when you are not giving any AED even. Okay, so 2% is the background risk of any congenital malformation. But all of these anti-epileptic drugs, they do have just a little bit, 1 to 3% risk of congenital malformations. Only the sodium valproate has the maximum of the congenital malformation up till 10%. And whenever you give polytherapy with valproate, means polytherapy means you give more than two or more than two drugs, then again the risk goes up to 10%. So here they are giving valproate along with another drug, so it would be reaching 10%, not below 10%. Lichen planus maximum symptoms, this is erosive lichen planus, most common diagnosed cancer during pregnancy and breastfeeding, always in the woman, it is a breast cancer. Chances of cancer with HNPCC, so we have discussed 40 to 50% basically they usually say. So here 50% is not option, otherwise 60 we cannot select, 40 to 50% you need to select this option, okay. Diaphragm is pierced by IVC and aorta. What level does aorta pierces diaphragm? So this is the T12 level. Vulval lesion on biopsy, keratin pearl. So these are typical of squamous cell carcinoma. Most effective emergency contraceptive is always emergency contraceptive is your copper IUCD. 20 weeks gestation, they are just asking you about the risk of developing pneumonia in the baby because it develops a chicken, not in the baby, in the female patient. The mother develops chickenpox with rashes all over the body. So it may end up in the disseminated chickenpox, and that is very lethal. So we may have 10 to 15% risk of pneumonia. Okay, so just a brief understanding of drugs, that some are enzyme inducing anti-epileptic drugs. Enzyme inducing means they are inducers of cytochrome P450. So they metabolize other drugs which are metabolized by that cytochrome. So you all know that the estrogen, they are actually the metabolized by those cytochrome P50. Now what happens is that when you take these two combined drugs, like you are taking OCBs and you are also taking some enzyme inducing anti-epileptic. So what happens is that this enzyme inducing drugs, they are actually inducing more metabolism of these the liver, those hormones. So more metabolization and more OCPs would be like metabolized, so the concentration would be reduced. So that is why we cannot take hormonal contraception along with these enzyme inducing drugs. So that is, if you remember, we have discussed the UK-MAC criteria. So the 3 means the risks are more, means the risk we say like this, that because the concentration of OCPs decreases when you take enzyme inducing drugs, that is why it is not recommended. So always whenever you take enzyme inducing drugs, all the epileptic patients, only the IUCD are recommended. 1 means safest. Non-enzyme enzyme inducing, if the drug is non-enzyme inducing, then you can take anything, any contraceptive, okay. Lamotrigine is not an enzyme-inducing drug, but there is a combination with OCPs that this OCPs actually reduces this lamotrigine concentration. Only this point you just need to remember that OCPs actually can increase the excretion of lamotrigine. That is why you just do not take lamotrigine with OCPs. Otherwise, with lamotrigine, rest of all the contraceptives are UK-MAC1. So only remember that this carbamazepine, this phenytoin phenobarbital, these are enzyme-inducing drugs. So just do do not recommend these with these enzyme-inducing drugs any kind of contraceptives except intrauterine. See all these criteria they have written 1, 2, 3, and 4. Okay. See advanced renal clearance, which anti-epileptic is affected. So just I told you that the OCPs also increase the clearance, and also the renal, actually they are excreted by the kidneys. So advanced renal clearance, this would be affected. Okay, hepatic bud invaginated into septum transversum. This is already we have know the ultrasound. You remember the biophysics. The piezoelectric crystal. This is the main crystal which has the transducer, which is inside the transducer and converts electrical energy into mechanical energy and reverse as well. So this crystal actually are used in the ultrasound. The question is like this. So the question with the old age patients with lung cancer, lethargy, fatigue, polyuria, again the depression. So lung cancers, even the small cell lung carcinomas and all the malignancies, we have a very typical of hypercalcemia. They usually the calcium raised, and these are the symptoms of hypercalcemia as well: fatigue, polyuria, impression. Okay, so patient presented with irritating nodule on the incision site, sutures were used, absorbable were used, inflammatory cell would be found. So I will just see the options: neutrophil, Langhans, eosinophils, and macrophages. So you know that rest of all are just in the present in the blood. The tissue in the tissues, only the macrophages are present, and they are long lived. So when they take the any kind of bacteria, they stay there with the in the body. So they are present in these nodules. Okay, so this is again very important respiratory changes, and they're asking about the minute ventilation, how much increase. This is 40%. The LNP, whenever it is more than it's the periods are skipped, so you need to do the PT whenever the patient of reproductive age comes with the bleeding. So you need to first do the pregnancy test. This is again a repeat question that you don't have any sac, but there is a mass not differentiated from ovary, also the corpus luteal cyst. Then you need to just do the beta HCG 48 hours apart. Root value for obturator nerve, which is 234, IUCD missing thread. So this IUCD is again very important. So see, this IUCD would be hyperechoic, means more white, more brighter than the rest of uterus. And this is the endometrium. This is a whole endometrium. So this IUCD lies in the endometrium. It is in the uterine cavity. It is not displaced. If this picture, this IUCD, you see like this or like this is in the myometrium. So you need to pick these things. So IUCD, whenever you have a patient with the complaint of vaginal discharge along with IUCD, then you don't remove IUCD there and then. You leave IUCD, you take the swab, and then you start the empirical treatment. The swab taking is important. Okay, postmenopausal patient with the bleeding, and you take the ultrasound, and the thickness is the 1.2 mm. Then you don't need to go for biopsy. See, the next line of management: biopsy, hysterectomy, reassure, call the patient of bleeding recurs, insert Mirena, start pills. So basically, the most common cause of bleeding would be atrophic vaginitis. So not the most lethal is the most common. Always the most benign cause would be the most common cause. And this is the most common cause of postmenopausal bleeding. So you don't need to jump into the biopsy or jump into the hysterectomy. Just reassure the patient, if it recurs, then do come. These are the question with the MRCH we have discussed previously in very detail. So secondary sexual characteristics are normal. All the hormones are normal. It means the ovaries are functioning very well. Karyotyping is 4 to 6XX. Absent uterus. So it is MRKH. Okay. So pH. So pH is 7.36. PCO2 is 3.7. It is reduced. Bicarb is 9. Okay, so if you just see the patient with the nausea and vomiting, so maybe the patient with excessive nausea, vomiting, and any kind of symptoms. So now if you just see the picture of pH, you cannot say anything because the pH is in the normal range. So then you just need to remember what I told you in the lectures, that the compensatory, there are the compensatory changes. So with full compensation, you can say that with full compensation has already occurred. Now you need to see that what actually is the problem. See, if you just see that PCO2 is reduced, so PCO2 reduced means the alkalosis is there. Okay, but bicarb reduced, it means that acidosis is there. So these two are opposite thing. Now how you pick that which is the problem? So you see the the question, the scenario that the patient is the nausea and excessive vomiting may be there. So it means more of the actually everything is lost from the body. So it means this is the cause. So metabolic acidosis is actually the cause, and along with that the body has compensated. Now the compensation would be the opposite mechanism, that would be the respiratory alkalosis. So it means this carbon dioxide is reduced because of compensation. So this is metabolic acidosis with compensatory respiratory alkalosis. So that is how we um, solve these kind of questions. Okay, so metabolic acidosis, the excessive loss of alkali and all these causes. So you need to treat the cause first. So hydrate the patient first. MRI, hydrogen ion is there. Hyperemesis gravidarum. So thromboprophylaxis is indicated in the patients of hyperemesis gravidarum, but only till the patient remains in the hospital. When she discharged, then you have to, here's the question. Okay, so you have to then discharge the patient. So until discharge of patient, you need to give thermoprophylaxis. Vomiting in pregnancy, you need to give vitamin B1, which is thiamine, because of vernix encephalopathy. Decreases in pregnancy, all your residual capacities are decreased. Drug used for UTI not given in third trimester, you know, it is nitrofurantoin, and trimethoprim you not give in the first trimester. So do remember, first trimester contraindication and third trimester. BRCA is your tumor suppressor gene in human, which chromosome has telomere on one end. So we have discussed that in human they have asked you, and that would be the acrocentric. Okay. Okay, so mode of inheritance. When affected mother gives the condition to all her sons, father gives to both sons and daughters. Affected daughters will have either father or mother as affected. Means first generation is passing to all the next generations. Okay, so it means it is a dominant phenomena. It is not a recessive, no recessive pattern. Now differentiate between either it's X-linked or autosomal. So it means like see, affected father give the condition to both son and daughter. This is the main difference between X-linked dominant and autosomal dominant. When it is X-linked dominant, when the father has X-linked dominant disease, it means the father cannot transmit the disease to the son. Son only takes Y chromosome from the father. That is the difference, that this is not an X-linked disease. Autosomal disease, it means the father can equally give to both son and daughter. So it is not differentiated between males and females. So autosomal dominant is this disease. Brunner cells, see now the Brunner cells are coming, which is present in the duodenum. Prostaglandins degraded in, we have already discussed previously, 65% in the lungs. Carbon atom, alcohol group is at the carbon atom 15. Paralytic ileus due to hypokalemia, Down syndrome. So now the serum markers are very, very important. Do remember always the Down syndrome has only these two things elevated, beta SAG and inhibin A. And these two are only elevated in this Down syndrome. Edward, just remember everything is reduced. Everything, 1, 2, 3, 4, 5, everything reduced. So this is the differentiating point between these two. Urodynamic chart, basically it is not a part of you, but it's not a urodynamic, it's just a uroflowmetry. And here just the time to maximum flow. So this kind of bell-shaped graph is actually formed. This is the normal graph. Okay, so this was the picture of syphilis I have added here. Basically, the syphilis, you can say that these are very confusing questions about syphilis. And just still, I just tell you that there are two kinds of tests. One are the treponemal test, and then there are the non-treponemal test. Okay, so treponemal includes EIA, CIA, non-treponemal are RPR or VDRL. This happening. Okay, so they are the two kinds of tests. See, treponemal and the non-treponemal test. And always when this treponemal is non-reactive, then you can say that, okay, this is unlikely. But when it is positive, see reactive treponemal test, then you have to confirm with another test. Not on one test you say that this is a syphilis. Always, always do remember. So now you have to either repeat this EIA, we have discussed in lecture, repeat this treponemal, or you may go for other test, means non-treponemal test. Okay, so this is the possibility. So two tests you need to do. If it is again non-reactive, well, not again, it is non-reactive, or it is reactive. If it is reactive, then you can say that, okay, maybe previously treated or untreated syphilis. But if it is non-reactive, then you have to do the non-reactive second treponemal serologic test. Then you have to do repeat treponemal test. Okay, so this one test you have to repeat, because this actually non-treponemal does not come positive. So it means you can say that this is non-specific. So you have to repeat this treponemal again. So if it is non-reactive, then you can say that, okay, syphilis is unlikely. But if it is reactive, then you can say that it's either previously treated or untreated syphilis. So this is a very confusing, you can say that, but you just remember these 2 points, that whenever you have one uh, test like EIA or CIA, then you have to repeat with the other test, non-treponema test. It has gone. So this is how you need to go in the syphilis. Okay, so this is about the uh, your umbilical cord cut sections. There are two umbilical arteries, and this is the umbilical vein. So maybe ask this diagram. Ligamentum arteriosus is remnant of truncus arteriosus. Glucocorticoids secreted by the zona fasciculata. These are very, very important. You need to remember where corticoids are from this layer. Reticulosa androgens and glomerulosa mineralocorticoids. So these three you need to remember. Deltaparine is actually your, you need to measure anti-10A factor for efficacy. Warfarin acts by factor 10 inhibition. Fluconazole, so we remember that it is a ergosterol inhibitor. Cell wall synthesis is going to inhibit. Galactoria is caused by the antiemetics. 8 weeks pregnant patient, TSH is more 8, but T3 T4 are normal. So here you can say that TSH might be, it is not due to the beta HCG or anything, but it is raised, so it means there can be a hypothyroidism, but it is subclinical because T3 T4 are normal. Okay, so this is the question we have discussed in very detail in one recall, that how to solve this question. Speed of CTG paper is 1 minute, 1 centimeter per minute. Anterior pituitary development, all actually systems this starts developing in the 10 to 12 weeks. So first trimester. Common complement in all 4 pathways, C3 is the common complement, and major immune reactions if it is absent. So C3b actually it's very important for all the immune process. Adaptive immunity, your whole lymphocytes is a part of adaptive immunity. And for the pudendal block, you are going to give like the nerve supply of perianal area. So basically it is a branch of pudendal nerve. So it is an inferior rectal nerve which gives sensory supply to the perianal area. Pelvic diaphragm, two muscles, levator and iron coccygeus muscle. Lynch syndrome, the tumor suppressor genes were there. Ultrasound. See, this is the twin pregnancy. Now you need to, I'll give you another, I think, recall where both the pictures would be there, monochorionic or dichorionic. See this picture, that this is the very thin layer between these two. So this is the amniotic membrane, and the placenta is only one, and this is the very thin layer between. If it is a lambda, so this is about the T sign, and lambda means in lambda this would be the whole covered by the placenta. So means there would be the two placenta might be there, but here one placenta is there, so it is a monochorionic diamniotic twins. Okay, so pregnant patient with fatigue, intolerance to cold, swelling of thyroid gland, and they show some lymphocytes. It means that is Hashimoto's. Patients with PCOS has galactoria, so the cause would be always your PCOS, unopposed estrogen causing everything. Fetal hemolytic status assessed by direct Holmes test. The question is not here. Okay, so 5.8, 7.9, this is your OGTT test. So this is your GDM diagnosis. So always remember 5, 6, 7, 8. So this is the fasting level 5.6. If it is more, you have to diagnose GDM. If the postprandial, 2 hours postprandial is more than 7.8, it is diagnosed GDM. So previous rupture, scar rupture, 1 in 200 or 0.5%. This is important point. Ultrasound, like all the components, absorption, scattering, and the reflection. Basically, beams are reflected. So stats question will be solving in the stats. I have not added a stats paper in the recalls, but I have a paper including all the stats questions. So I'll add it up in later on. Okay, so not the test of cure. Basically, it takes approximately 7 days. Okay, So yes, heavy menstrual bleeding and the patient is not keen to conceive. So that is very important point. They're already giving you. So the first line of management for all the HMB is always the Mirena. Standard error of mean, the median. So median is just very easy thing. You just take the middle one value. Okay. So four lie here, four lie here. So one is the middle one. So you have to write it in chronological order. Number of carbon atoms in estrogen 18, prostaglandin carbon atom, not carbon atom, alcohol group attached on carbon atom is C15. Which organ is the site for urea synthesis? It is your liver, site of production of thromboxanes. So it is by the platelets, prolapse, vaginal prolapse. So which is the muscle would be involved? So you know that pelvic floor muscles are basically weak. Okay, so pelvic floor is formed by your levator ani, and the levator ani, the main part is the pubococcygeus. Okay, abdominal approach, if you give uh, prolapse, so main ligament. So basically you need to, even the McCall-Caldoplasty, so you need to apply the cardinal, suture the cardinal ligament. So that is very important. Just mute your mics, please. Okay. So cardinal ligaments are important ones to be stitched for prevention of prolapse. Fluid area or black area, always fluid or black shadow would be anechoic. Okay, there are no echoes in that. And with the posterior shadow, posterior enhancement, not posterior shadow, posterior enhancement would be there. Okay, Haldane's effect. So Haldane effect, we have not discussed in detail previously. So it is just the capacity, see, increased concentration of carbon dioxide. So whenever the carbon dioxide in the body is increased, what it do? It has a propensity to attach to hemoglobin, okay? Because hemoglobin is already attached to oxygen. So whenever the condition has carbon dioxide more, it will displace oxygen from hemoglobin. What it do? It split this HBO and remove the oxygen, okay? And binding of oxygen to hemoglobin will displace carbon dioxide from the blood. Okay, so this is just the opposite. Whenever the carbon dioxide is more, it will dissociate oxygen from the hemoglobin. But whenever the oxygen is more, then what it do? With it will dissolve, like dissociate carbon dioxide. So binding of oxygen to hemoglobin will displace carbon dioxide from the blood. This is known as the Haldane's effect. Okay, so the strongest ligament helps in standing upright is always your iliolumbar, your pelvic ligament, that is very important. Sacroiliac joint, synovial joint, glucose 6 phosphatase. Tase means this would be removed. So phosphate would be removed from glucose 6 phosphate, it converts into glucose. Calcitonin is secreted by your thyroid gland. Ureter crosses the bifurcation of common iliac artery when it reaches the pelvic brim. This is very important. Ureter roots, very important. HPL plateau, just we have tell that it is 35 weeks. So the peak or plateau occurs at 35 weeks. Homologous to the bathroom gland are bulbourethral glands in the male, which is Cowper's glands. HPL is secreted. See, this was the question I think previously, syncytial trophoblasts. So trophoblastic cells actually produce all this. HPL means placenta. Labetalol. So yes, labetalol is alpha 1 and also the beta 1 and beta 2 blocker. Not only the beta blocker, it has alpha 1 as well. So selective alpha and the beta, non-selective beta blocker means both beta 1 and beta 2. Win3, all your vulval intraepithelial neoplasia also has organism 16 and 18 involved. Nerve passes medial to the anterior spiralic spine, which is lateral cutaneous nerve of thigh. Suprapubic incision level would always be your L1. Uterine pain sensation can be blocked. So T10 to L1 is the level when the uterine pain so perceived. So you have to be blocked. Lowest level you have to go for the T10. Amniocentesis risk of miscarriage is basically 0.5%. If there is the option, you need to select that. Otherwise, 1%. Hyperprolactinemia, it's called by the adenoma. Okay. So the patient is having shortness of breath, hemoptysis, coming to ER, history of miscarriage 3 months back. So it is a very, very typical, this X-ray picture is very important. You know, the cannonball picture of choriocarcinoma. That is very typical. So whenever the pregnancy is preceded, means previously either it is a miscarriage or even it is a normal pregnancy, it can go in form into the choriocarcinoma. Okay, so all these symptoms are about the malignancy, and this typical X-ray picture is about the choriocarcinoma. So which tumor marker should be checked? So always beta acidity needs to be checked. Okay, so again, a South Asian woman, lethargy, low-grade fever, dry cough, loss of weight, residing in UK, chest X-rays as follows. So again, the tuberculosis, you see the hilar enhancement is very important here in this X-ray. Usually they do not ask you about this tuberculosis, but you may be skipping, like rule out other conditions. Like pleural effusion would be very typical, no, bronchitis would have no typical feature on, and even the symptoms does not correlate with that. And pneumonia would be very acute presenting, not loss of weight is going from last 6 months. So always whenever there's anorexia, weight loss, either the tuberculosis or any kind of malignancy would be there. So these two differentials would always be there. So pneumonia would be having a typical picture of a patch, and tuberculosis has a difficult, not a typical picture. Okay. Okay, so 2,3 diphosphoglycerate in pregnancy, the curve we have discussed previously, this is the curve, and this curve shifts to the right whenever the 2,3 DPG increases or any kind of acidosis. This curve shifts to the right. Clomiphene citrate is your selective estrogen receptor modulator. Breast CA, always your BRCA mutation would be there. Progesterone implants, mechanism of action, all I think the POPs or implants or even depot, inhibition of ovulation is there. But the older one, traditional POPs, you may say that they are not very effective in inhibiting ovulation. So those POPs, their main mechanism of action is the thickening of cervical mucus. Remnant of mesonephric duct in females is the Gardner's duct. Which organ will be affected by ACE inhibitors? It is your kidneys. Plasmodium species, heaviest burden. Always the falciparum is the worst and heaviest burden. Okay, so endometrial picture, that enlarged and tortuous glands showing vacuoles. So this is the typical secretory phase endometrial changes. Most common cancer tube in fallopian tube is always your serous adenocarcinoma. This is again a repeat question. When SAC is 2 mm, then beta should be around 1,000 to 1,500. Warfarin teratogenicity is 6 to 12 weeks are very typical of like very uh, teratogenicity can occur when you take warfarin during that period. Clehor-Betke test, because they are fetal hemoglobin are resistant to acid. So Clehor-Betke test we use when we are checking the hemolysis. Which signaling molecules stimulate the renin system to regulate the sodium concentration? That is the aldosterone. Best indicator for thyroid function in pregnancy, always your serum TSH. If there is a T3, T4, then only free T3, T4, but serum TSH is actually the best. You need to first see the TSH, then you have shift to the, like if it is raised or reduced, then you can go for free T3, T4. Patient has bradycardia, cervical lesion, pain in the cervix is carried by which nerves? So all the autonomic or pelvic splanchnic nerves. Type of study in case of shoulder dystocia and internal weight. So again, this is not a complete question. They have not tell you that what either they are going to see the records, because this seems like it is they are just seeing the records, because shoulder dystocia would already be occurring, and they just go backwards and they see that okay, how many of they are obese and how many are non-obese. Okay, so shoulder dystocia is the main like outcome, and they are the risk factor is just they are seeing which is the maternal weight. So maternal weight is more, the risk of shoulder dystocia is more. This is actually a risk factor. So this can be a case control study, that they are taking the cases with the shoulder dystocia, and then they are just seeing that, okay, how much are with the having, how much were obese and how much were non-obese. Okay. Advantage of using carbon dioxide laser for endometriosis is that, okay, this does not spread. That is the only advantage of carbon dioxide laser. Isoniazide is metabolized by acetylation. P-value significant is always when it is 0.05 and less than 0.05. Okay. The rest of all are more. So less than 0.05 is always when P value is significant. So with this, we have ended our today's lecture. Any question up till now? Hmm, any confusion or any question? No question. Okay, so then let's end our today's class. Okay, so now the Eid holidays are coming, so I wish you very good Eid Mubarak for all of you. So do enjoy your Eid and take 2 3 days rest, and then rejoin your study. Okay, to you, thank you so much, Dr. Bina. Okay, so I think we will be resuming our classes from next Wednesday. So one whole week is free for you. So do cover all of your remaining portions. Like if you are lacking behind the theory, then do revise those portions, and do practice any other MCQ book if you have that, and do try to post the questions in the group. I see the long post students, they do not post questions. Dr. Bina, you are in the long course, and previously you people were very active in the group, but the recalls and crash course students, they are very active in their group, so they do post the questions, and uh, that is a good point for the discussion. So do try to post the questions whenever you have any query, or whenever you see there is a difference between the key and the actual answer. So do post that in the group. That is a good point for practice of all the other students. Okay. Okay, so let's end our today's class. So good luck and Allah Hafiz.